and welcome to another pod. Today we're going to continue with pathophysiology and we're going to talk about special senses. So just as a means of completeness, I wanted to make a short video on special senses type problem and mostly focusing on those that affect your vision and your hearing. So it won't be a full hearing or visual problems, it's more of a overview, common conditions that you can see. Okay, but we'll get stuck right into it and we'll start by looking at just an overview of the eye. So just running around the structures of the eye. It's one of those incredibly complex organs. It contains 70% of all of your sensory receptors. But just moving around, we have the sclera, which is the external protection. It's the part that we see, the white part around the eye, and it just holds the focus of the globe. Then we have the cornea. The cornea is the part that is transparent and it's used to refract light. Okay, so it has a huge part to play when you're dealing with pathophysiology. The choroid itself is the coloured part, so it contains coloured pigments made of melanin, and it has a huge amount of blood supply within it as well. So that's also the part where the photoreceptors will sit. The iris is a contractile part of the eye that controls the amount of light that can enter the eye. Ciliary body is associated with muscle changes, focusing the lens, and the secretion of aqueous humor. The lens is just that. Okay, it's a lens used for reflecting light. The retina is the photoreceptors. So the retina is another way of saying the layer that contains the photoreceptors, and that's the one that transforms the optical signals to the nerve impulses. And that's made up of your rods, which is distinguishing light from dark, so it's one that sees in the dark, and your cones are all about detecting the light. Now your macula is a very special and central part of the retina, and that contains the largest amount of cones. So most of the cones in the body, which only take up about 20% from memory, is found in the macula itself. As we look external to the eye, we have a huge amount of external ocular muscles, and they're involved in the movement and the coordination of the actual globe itself. We have the optic nerve that moves from the back of it and all the way to the brain in order to pass on the action potential that can go on to further interpretation and perception within the occipital lobe. From there, other things of point before we start talking about pathophys is your conjunctiva. It covers the sclera and the inner surface of the eyelids as well. You also have specialized lacrimal glands, which are responsible for secreting tears, but the tears contain specialized antibodies, mucoids, and lysosomes themselves. So a point to note with most of the structures in the eye is they don't actually have their own connection with the nervous system itself. So it needs to rely on specialized antibodies and lysosomes found within the lacrimal and the aqueous humor in order to fight infection, and it's also involved in its own version of self-repair as well. Okay, looking at the functional visual problems, a way to define normal healthy lens is that it's flexible and its shape can be changed with the ciliary muscles. So what I mean by that is if you're looking at something in the distance, the ciliary muscles will contract and they'll actually flatten out the lens. Whereas if you look something close to you, nearsighted, the ciliary muscles will relax and the lens will become more convex. That's what happens normally. Now if you can see something at 6 meters and it appears normal, you're known to have emmetropia. That is normal vision. If you have refractory errors, then that's what causes visual problems. So they're actually related to the inability to compensate with refractory parts, and then from there they don't pass the light to the back of the retina for interpretation as well. Okay, so there's a quick overview of how visual works. If you feel you need more information, I'm not going to go into more information in this video because, like I said, it is an overview, but you can go back to anatomy physiology on the special senses. Part 2 is all about the eye and how and how it actually works. Okay, so just focusing on visual problems, the two common ones is hyperopia and myopia. So myopia is short-sightedness, so it has the inability to focus on things closely. So as the light comes in, the focal point is too forward of the actual back of the retina. Okay, so in this case the eyeball all the time is too long, or the lens itself is unable to be shaped in order to hit the light at the back. So two different types of causes. Whereas hyperopia is for long-sightedness, so you have the inability to focus on things that are close to you. Now in that case, the eyeball is too short, or the lens refracts the light behind the retina, so you'll end up with visual problems. Now the different type of visual problems can be presbyopia. Now this is just the inability to focus on close objects as the lens becomes less visible. So it's more of a aging condition. So as you get older, you'll end up needing glasses to read. Okay, and that's called presbyopia. And astigmatism is a very, very common one, but this has got to do with an irregular shaped or a very bumpy or not a smooth shape of your actual lens itself, and also your cornea. So your cornea is lopsided or a little bit irregular, which means as the light comes in, instead of having a nice clear pathway, it ends up activating different areas of the retina. And that, obviously, the retina is filled with photoreceptors, you'll actually end up getting a mixed message. So what you'll get is blurred vision, double vision, things that are out of focus, because your brain can't interpret all these mixed messages from all the signaling that's happening within the eye. Okay, moving on to some common infections, we'll just move around. So depending where the infection is within the eye, you'll actually have a different name for each one of those. So endophthalmitis is an infection of the actual globe itself. Okay, so as I mentioned before, it doesn't have its own immune system, so it pretty much has to ride itself out, get killed by lysomes, and then go through self-generation. Keratinitis is an actual infection of the sclera or the corneal wall itself, and your conjunctivitis is inflammation of that conjunctiva that we spoke about, so that protective layer that goes over the cornea and under the eyelids. So just looking a little bit more at that, because it's far more common than the others, it's caused mostly by viral or bacteria. Okay, but it can be caused by allergens, even sunlight can cause conjunctivitis, so too much direct sunlight. Physical irritation as well, so grit, sand, all that sort of stuff in your eye, and then toxins, okay, alkaline or acidic toxins can cause it. Now what happens with the clinical features is you end up with massive irritation, so they'll feel like there's actually something in their eye. You'll have redness across the eye, and you'll often have discharge as well. Okay, now depending on the type of infection or causative agent will usually determine what the discharge is. Now trachoma is another way to define chronic conjunctivitis, and it's usually caused by chlamydia itself. So it is the most common cause of blindness itself. So if you end up with trachoma or a chronic chlamydia infection of the eye, you'll more than likely end up being blind. And some predisposing factors include obviously poor hygiene and living in overcrowded areas. Now, what this condition does is it leads to scarring of the eyelid, okay, which causes your eyelashes to actually rub on the cornea. Now, this cornea scarring is what we call that keratinitis, and that's what starts the visual problems itself. So the scarring of the cornea lens itself is what leads to blindness. Now, a acronym, so it's called the SAFE strategy, was developed by the World Health Organization for the management and prevention of this trachoma. So the way to fix it or prevent it is if anyone has any eyelid deformities, droopy eye, bulge in the eye, cyst in the eye, then surgery is recommended, so then you don't get this constant rubbing effect. The early treatment of antibiotics for conjunctivitis, facial cleanliness is another one. So now we're up to the F of safe. So keeping your face clean to help prevent the spread of chlamydia, and then improving the environment that you live in. That one was sort of thrown in there because they wanted it to say safe, realistically, because it's sort of obvious. Right, but that's generalized eye infections. Another thing that can affect the eye, and does affect a lot of people, is cataract. So this is your ossification or an opacity of the eye, which interferes with your vision. So it's actually a growth within the eye that interferes in the vision. So senile cataracts is the most common form, and unfortunately the cause of that is unknown. But secondary cataracts can be caused by identifiable events of certain diseases. So trauma, radiation toxicity, inflammatory processes of the eye, and diabetes can cause secondary cataracts. So clinical features will lead to blindness, but it will be a slow and progressive blurry vision, and you'll see essentially what you see on the picture in front of you, the formation of this opaque sort of lens over the top of the eye. Now, another thing that affects a lot of the oldies is this macular degeneration. So remember before I mentioned the macula is the central part of the retina that contains most of the body's cones. Okay, so macular degeneration is the loss of retinal pigment cells in the macula. So you have this inability to associate colours, and it actually leads to a type of blindness. So the macula has a massive high oxygen demand. Okay, your cones create action potentials very quickly, and they need to regulate, so they have a huge demand of oxygen, huge demand. So because of that, in the absence of oxygen, they are really susceptible to ischemia, and that's a lot of the time what causes this macular degeneration. So the main cause in age-related macular degeneration is 70% inherited. From there you have your other things that cause that lack of oxygen. So smoking is a huge one, and then hypertension, especially hypertension, retinopathies, which we'll look at next. But another type is your diabetic macular degeneration. So that is poorly controlled diabetes, will obviously cause an increase in atherosclerosis around the eye, leading to a decreased circulation and oxygenation of the back of the macula itself. Okay, talking about diabetes, we'll have a look at another thing that is caused by them. Before then, we'll look at our hypertensive retinopathies. So sustained hypertension or a sustained increase in arterial blood pressure will cause damage to the vessels in the retina. That's just what happens. The retinal vessels are very small, very fine, so prolonged hypertension will lead to their damage, either by narrowing of the retinal arterioles or bulbing or sausaging of the veins itself. So the reduction in blood flow will obviously lead to ischemic type damage. And areas of hemorrhage, so small pockets of hemorrhaging, can also develop. If you get severe hypertensive retinopathy, it's associated with edema of the optic disc itself. Okay, so papillar edema can be a secondary effect of your actual retinopathies. Now, another type of retinopathy that occurs is your diabetic retinopathy, which is denoted by the picture on your right. So damage to the retinal blood vessels by diabetic retinopathy causes edema and hemorrhaging within the eye. From there you get the ischemic damage, and you end up with reperfusion by formation of new blood vessels. And obviously as a result of that, you end up with fibrosis forming. So you get internal inflammation of the retina, and from there fibrosis will develop, and the retina itself can detach. And when that happens, you get associated blindness. Okay, glaucoma is another one that affects people of age, but can also be associated with a lot of medication and condition. So all glaucoma means is an increase in intraocular pressure. So when the intraocular pressure increases, it compresses the arterioles and the capillaries, which reduces oxygenation to the retina, again, which has you having a progressive loss of vision, usually peripheral to central tunnel vision, meaning it's like the curtains are closing on your life, is what people will say. So what causes it, the pathophysiology simply put, is a disturbance in the circulation and drainage of the aqueous humour. So normally speaking, the aqueous humour is secreted by the ciliary bodies, and they're found in the posterior chamber at the back of the eye. And then as they travel through to the front, they're reabsorbed into the venous circulation via what's known as your Schlem canals of the anterior chamber. So as the pressure builds up, they leak into the Schlem canals, and then the pressure is sustained. So two different types of glaucoma that you can get is closed angle and open angle. Nice and easy to remember. So closed angle is where the anterior chamber is actually quite shallow, which means the overflow of aqueous humour is impeded, which means the fluid can't actually get into the Schlem canals, meaning you don't actually have that normal flow and replacement of it. Okay, so you'll actually have a tubercular meshwork that covers by the root of the eye of the iris itself. And they say that it is a lot worse when the pupils actually dilate. When the pupils dilate, this angle will actually get narrower itself and therefore worsening the problem. Whereas open angle glaucoma, there's no obvious pathological changes at all because the shape and everything is normal, but what happens is you actually have a blockage just before or of the Schlem canals itself, and that will actually prevent the drainage of the fluid. Now this is more common in people over the age of 35, and it is a very slow progressive condition. Two more things that we'll talk about with the eye, just to keep it in mind, is you can get certain tumours of the eyes. Just want to mention things like retinoblastoma. They're mostly found in children, but it's still a rare childhood tumour that affects the retina itself. Now, of the cases that affect children, 5% of those cases are hereditary, so the other causes are still quite unknown. What happens in advanced retinoblastoma is it would lead to the actual whitening of the pupils and the loss of what's known as the red reflex. Now, another thing that really affects the eyes that most people don't associate is malignant melanomas. Okay, so this is the most common primary tumour of the eye that affects adults. So remember that the iris, the ciliary body, the carotid all contain pigmented cells that produce melanin. So they're pretty much identical to the melanocytes found throughout the body. So when you get malignant melanomas, okay, your eyes can actually go through the same changes due to UV, that sort of thing. Okay, so when this happens, because malignant melanomas have a huge rate of metastasis, it usually requires complete removal of the globe itself. Alright, we'll move on to the ear. We'll just have a quick look. So the ear simply broken up into three areas. Okay, so you have your external ear, which is your auricle or pinna, and that's elastic cartilage covered by skin. That there is responsible for collecting the sound waves and directing them down towards the eardrum. The external auditory canal is said to be a S shape that ends at the tympanic membrane. Okay, it's a very imaginative S shape, but you can sort of get the idea, and it ends at the tympanic membrane. And then we get to the middle ear, which is a air-filled tympanic cavity, and that is where the ossicles sit, and they're essential for transmitting those vibrations into the inner ear for interpretation. Now the inner ear is where the vestibules, the semicircular canals, and the cochlea is actually found, and these are the ones that are linked to your cranial nerve 8, which transmits the signal to your auditory cortex in your temporal lobe. Okay, so that's nice and easy. Like I said, if you want to know more, go back to anatomy physiology and you'll definitely get a good idea of how it all works in a lot of detail. Okay, but looking at infections, we have a lot of different infections that can affect the ear. Starting from external, we have otitis externa, which is also known as swimmer ear. It's also subject to a lot of trauma. Infections of the middle ear, they're associated around your glue ear or otitis media, rupturing of the eardrum. You can always get mastoiditis as well. Pretty much that is it when we're dealing with the middle ear. Now the inner ear, that's when we get our associated deafness. So Meniere's disease, vertigo, that sort of thing. That's the conditions that affect the middle ear itself. But we'll just take a closer look at otitis media because it is quite a common disorder, especially when you're dealing with children. So it often follows a viral upper respiratory tract infection, and it's what's called a serous otitis media. So if it's viral, the fluid that's found in it is going to be serous. Okay, if it's a bacterial superinfection, then you can actually start getting that plurulent otitis media. So the actual fluid will change. Either way, the general features is you'll have ear pain, you'll have hearing loss, you'll get bulging, discoloration of the tympanic membrane, and you can get pus discharge from the tympanic membrane if it ruptures. So this is often seen end stage. You'll just see the bulging first. So from there you can obviously get chronic otitis media. The infection can spread to the mastoid bone. You can get pain in the TMJ. It can also travel the other way. So it can go to the inner ear and then to the brain and have associated meningitis, things like that. When it turns to chronic otitis media, this is usually defined as a complication or a reoccurring acute otitis media, and it can follow traumatic rupture of the eardrum. So this glue ear is a form of non-bacterial chronic otitis media, okay, which means people constantly have this build-up of this plurulent discharge, and is often treated by the placement of grommets. So it's very common in children that have really small eustachian tubes or really large adenoid. It blocks the eustachian tubes to get this build-up of fluid. So its clinical features is huge amount of pain, constant discharge. The kids will go to sleep and they'll wake up with a pillow covered in it, and then hearing loss itself. Speaking of deafness, okay, it's a very common symptom and very common disorder, but just to let you know, there's certain classifications of deafness that you can test the difference with. Obviously a good way to do it is with a tuning fork. You can tell the difference between conductive versus sensory, and sensory is more of your neural type problems as well. So conductive deafness is an associated problem with the external or the middle ear itself. So if you have lesions in there, or if you have build-up of wax, you have a foreign body, anything like that, you can get this conductive deafness. It also includes a loss or a rupture of the tympanic membrane and otosclerosis as well. So inflammation and damage to the ossicles themselves is classified as conductive deafness. Sensory deafness is different. That's got to do with cochlear abnormalities. So the message is getting down okay, but the signaling is not actually getting sent. So you can still hear sounds and can actually interpret that. And that goes hand in hand with neural, which involves lesions of the cranial nerve 8. All problems with the central nervous system. Now, a pretty common clinical test for things like this is called the Renner's test, where you get a tuning fork. It has to be 512 hertz, otherwise it can get too loud. And then you test the difference between air conduction versus bone conduction itself. Okay, so if you don't fully understand how to do that, then you can look it up on the other videos. Okay, well that finishes, like I said, nice quick one, special senses, pathophysiology. Hope you got something out of it. Okay, but until next time, take care.